Thank you very much, and thank you for inviting me to this wonderful conference. I've been invited many times, and I'm very honored to be here this time. Thank you so much, Professor Joe. My financial interest in this talk is that I did develop Presbyopia, and so we have a patent on this, and this is with Carl Zeiss. I want to just start with a little bit of history. 2006, I arrived here to visit Professor Joe, and we performed some surgeries together with some very early work in what were called shot files, where we were using spherical aberration to change the depth of field of the eye. So this is a very long relationship that I have with the ENT hospital and Fudan University. The challenge of presbyopia is that we are trying to fix the loss of a dynamic system called accommodation with a static solution. And in order to have all of the features of natural vision, clear distance, intermediate, near vision, good night vision, good quality vision, binocularity, stereo acuity, short adaptation time, simultaneous correction of refractive error, cylinder, the ability to reverse the procedure, the ability to fix complications. There's always going to be some kind of compromise if we're using a static solution. Now I'm going to summarize the last 20 years of presbyopia correction here. Of course, most people think of multifocality. They think of trifocal intraocular lenses. They think about corneal inlays, which cause multifocal corneas, or ablation profiles that cause multifocal corneas. Monovision, of course, is the original method of treating presbyopia with contact lenses, or with cataract surgery, or with LASIK. But we have arrived 20 years later at essentially the same solution for all of the industry. And everyone is now essentially following in the footsteps that we initiated 20 years ago with what is now called Presbyopia. Presbyopia is a modification of binocular vision, and it preserves stereo. So after 20 years of diffractive optics and multifocal refractive optics and monovision, now the intraocular lens companies are following the footsteps of the work that we did 20 years ago, starting using spherical aberration to increase depth of field and modify binocular vision. How does spherical aberration work so well? Well, it works well because it is a natural aberration of the eye. A 20-year-old has zero spherical aberration. The cornea is aspheric. The lens is aspheric. There is no spherical aberration in the eye. As we get older, the lens grows. As the lens grows, it becomes more spherical. As it becomes more spherical, we get more spherical aberration in the eye. And so the brain is filtering spherical aberration as we get older. A 20-year-old has about zero spherical aberration. An 80-year-old has about 0.8 microns of spherical aberration, and it increases gradually with age. So when we're talking about using spherical aberration for increasing depth of field, EDOF, we are not talking about a multifocal ablation. This is not multiple foci in the same eye. You see, a normal ablation profile would look like this. The Presbyopia profile looks different. You see, we have slightly more ablation in the mid-periphery, which essentially you can say increases the optical zone or decreases the induction of spherical aberration. And this is giving us natural, normal topographies post-op. This is very different from the previous corneal solutions for presbyopia, which are all multifocal corneas. Center for near, mid-periphery for distance. The theory being that as the pupil gets smaller, the eye can be more myopic. and you will see better up close. The theory is not good in practice because these are very high order aberrations, and you get loss of contrast and poor visual quality. So you get topographies that look like this, which of course we know are not satisfactory in the vast majority of patients. So I want to emphasize this. Presbyond is the only corneal solution that does not use multifocality in the cornea. And so when people think about corneal solutions for presbyopia, they think bad because of the history, because we have been talking about multifocal corneas. We are now in a different era where we're using spherical aberration. It's a continuous curve, and it does not produce strange topographies. So you all know from theory that a perfect aspheric system focuses at a point. The problem with a focus at a point is that there's no depth of field. When you introduce spherical aberration, you smear the point, you stretch the point. It's called extended depth of field. Now, it means that the image is slightly degraded on the retina, but it also means that you have more depth of field. Now, I'm going to demonstrate this to you. This is spherical aberration down here, and we know that the brain is good at filtering spherical aberration. It's not good at filtering asymmetric aberrations, like coma. This diagram shows you how your brain is filtering spherical aberration. This is an experiment we're going to do right here in the room. If you look at the top row, this is defocus in terms of sphere. Now, if we look at -150 sphere, you see there is a lot of blur, and you can maybe only see the O. With the same -150 defocus, adding spherical aberration, now you can see almost all of the letters. And that's because your brain is filtering the edge produced by the spherical aberration, and it's increasing your acuity despite the same defocus. So when we're talking about presbyond, when we set one eye with some spherical aberration at plano and one eye with spherical aberration at -150, the brain is not, this is the retinal image of each eye, but the brain is filtering this. And so actually, the patient is combining these two images. And that is why presbyond works well in almost 100% of people, whereas monovision, where you're trying to combine a clear image and a very blurred image, requires suppression to work. And suppression is only possible really in about 60% of people. Whereas presbyond is binocular, and so it doesn't require suppression. So in summary, the non-dominant eye is set to -150. With spherical aberration, it has increased depth of field. Remember that even old people, when they accommodate, the pupil gets smaller, so you get some meiosis. That increases the depth of field also. So the retinal image is actually a spherical aberration image with some depth of field from the small pupil, and then the brain filters the retinal image to produce an image in the mind that is clear. So this is the principles. We described this in about 2004. A few years later, the laboratories that had adaptive optics devices were using the adaptive optics to put spherical aberration into the visual pathway and test the extended depth of field in humans using the neural function. And what was very interesting about this was that they found what we described clinically, which was that, of course, if you have negative spherical aberration, the pupil gets smaller, you become more myopic. But if you have positive spherical aberration, the pupil gets smaller, you become more hyperopic. So in terms of ray tracing, this doesn't work. Positive spherical aberration would not work for increasing depth of field. But look what happens. This is the spherical aberration in the positive direction, increasing the depth of field. And we described a limit of 0.6 in our first paper, and Dr. Rocha demonstrated that above +6, either +6 or -6, you get a toxic effect of spherical aberration. So you want to think about spherical aberration as a drug. If you have too little of it, then you don't get an effect. But if you have a therapeutic amount, you get an effect. And if you have too much, then you lose contrast and you get night vision disturbances. Now, we know, as you can see from the graph, that we can increase the depth of field about 1.5 diopters before it becomes toxic. So 1.5 diopters is essentially what we can do on the cornea. If we wanted more spherical aberration, we would just lose contrast. So we start with 1.5 diopters of increased depth of field, and we use a small anisometropia in order to cover distance to near, 3 diopters essentially. You see, the near eye, like I said, is nominally set to -150, but because it's -150 in the middle, in front it's -0.75, and behind, it's -225. You understand? -150 in the middle, -0.75 to 225. That's -150 range. The other eye is set to plano, and it has a -0.75 equivalent at near. So both eyes have -0.75 at intermediate, and that means that there is fusion, right? It's like a Panam's area where the vision is the same at that distance. The results of this are very impressive. We have published this over 15 years ago, these first publications, myopia up to -850, hyperopia up to +6, and emmetropia. And you can see that the 20/20 J5 rate, which is newsprint, is 98% of patients up to -8, 95% of patients up to +6, and 97% of the patients who are plano presbyopes. If you look at 20/20 J1, J2 rates, it's 95, 77, and 95% for emmetropia. So you cannot achieve these results with lens calculations because we have a lot of too many variables in IOL calculations. But we have the advantage of using LASIK, which is an extremely accurate procedure. So we have the advantage of LASIK with the control of the spherical aberration. That means we have, of course, it's LASIK, so there's no loss of 2 lines. And because we're controlling the spherical aberration within the therapeutic range, there's no loss of contrast. And all of the challenges of monovision are taken care of. For example, the intermediate loss is taken care of because both eyes fuse in the intermediate. You can see here over 200 patients up to -12. All of them had computer size font 12, up to +6. 300 patients, all of them computer size font 12. Why is blended vision, presbyon, more easy to tolerate than monovision? Well, it's because the near vision of the distance eye and the distance vision of the near eye are worse in monovision. When we have presbyon, the near vision of the distance eye is better, and the distance vision of the near eye is better, and so it's much easier for the patients to fuse. And so we don't have binocular problems. Someone asked yesterday about convergence insufficiency in myopes, for example, and you have a monovision, you can get someone breaking down. But we don't get that in presbyon because it's still binocular. If they have an esophoria, it won't show because both eyes are fixating. Finally, there is no loss of distance vision from neural subtraction, which you observe in monovision, and we preserve summation. You see, 80% of the eyes are 20/60 with a -150 refraction. Now, -150 refraction, you would expect the vision to be 2100 in a virgin eye, but we see 80% of them seeing 20/60. Now, that means that the distance vision, 92% in all these eyes, goes up to 96% binocularly. So there is summation of the vision from both sides, not subtraction. Finally, stereoacuity. We studied this early on, and we looked at the safety of stereoacuity, and we found that there was no loss of stereo acuity, which we do see in monovision with -150 or more. That is a well-known fact that you can break stereo acuity and it doesn't come back if you break it. We also were very surprised that people after Presbyond still had near stereo acuity, even though the distance eye was set to plano with the depth of field. And 100% of the patients had 400 seconds, and over 75% had 100 seconds or better stereo. This data has been reproduced by Andrea Russo in Italy, just to confirm. Finally, what happens if the patient is not happy? Well, the beautiful thing about Presbyond is that if the patient is not happy, in 1 minute, you can make them happy. You make spectacles and you reduce the anisometropia, and they're happy. They have their vision back. Or you can do a simple standard enhancement, and they're happy again. You don't have to do any weird topography-guided central island treatments. Now, Presbyond is not new, okay? There are now 17 peer-reviewed publications in major journals. And there are almost 500,000 procedures that have been done outside of China. I know that once we start here in China, it's going to be 400 million procedures, but we're waiting for that. But you see, when we look at the statistics of patient satisfaction, we see that almost all of the patients are satisfied, that there's almost complete independence from spectacles, that there is no dysphotopsia. And this is the study by Sri Ganesh, and this is the study by Andrea Russo showing exactly the same thing. Almost 100% spectacle independence and no dysphotopsia. These are summarized, all of the results that have been published in the literature, and you can see essentially it's very consistent around the world. Around the world, everyone's getting the same results. The enhancement rate in our first two publications was 20%. That's because we were using the Hansatome. When we switched to the Visumax, the enhancement rate for the emetropia study went down to 10%. And that is approximately what we expect, about a 10% enhancement rate. 2 years ago, we published a paper on commercial pilots. This is a series of 23 British Airways pilots who came through our clinic, and we analyzed the results. There were hyperopes and myopes with astigmatism, and the results were, of course, fantastic. And the patients made a questionnaire of their own about the difficulties that they were having in the cockpit with 7 distances. And they learned, and we were able to apply this questionnaire before and after surgery, and the publication shows an immense improvement in safety for presbyopic pilots. Finally, as we started teaching the course, surgeons were starting to ask to have surgery. And this now became an avalanche. And we have like a huge number of patients. In fact, on December 31st, 3 days ago, one of your colleagues underwent Presbyond for low myopia. He was minus 0.75 in both eyes, and here he is immediately after the procedure. And as you probably saw in the People's Daily, this was reported. And I don't know if you can run up here, Professor Baiji. Can you run up here? And we were, that night, we were out walking around Chongqing, and he said, "I can see the stars." And I said, "I can't." Could you speak in Chinese about your experience and why you decided to have this done?
Just in English, no, it's okay. Finally, I give you English. 确实是我去年的最后一天做的一个手术，因为来讲我就跟随这个手术很长时间了。那么到了去年的5月份，我专门到了他们中心，因为我要去德国，所以来讲当时没有在他那儿做。那么今年年底把它做了，所以我刚才说用2个例子用把这个手术效果怎么样，我不用说这个手术效果怎么样。第一，我刚才跟大家一块儿是用的这个，我们说来讲看的这个立体的微丢，没问题。第二，我用的我的手机。 是用的最小的字号看的，没有调整字号看的。那我看远处也不用戴我的眼视镜儿，所以我说来讲，对我来讲呢，得介绍一下我自己。别的不介绍，第一，我今年2025年66岁。36 years old for me。第二来讲呢，对我来说，我希望我自己是这样子的人生，我希望我自己有很好的、很高的一个生活质量。所以说来讲，尽管我可以允许我衰老，但我总要面向太阳，这就是我的人生哲学。我要提高我自己的生活质量，所以最后我还是用3个英文词来给大家回答我自己的感受 ：younger, weaker, tiger。Thank you.
Very good. Thank you, thank you. I'm sorry. I'm sorry to ask you, the very unconventional of me to bring him up on stage, but you know, it's jazz, right? Let me show you that we actually are about to publish the results of Presbyopia in ophthalmologists. In other words, doctors taking their own medicine. And as you can see, we're treating a wide range of hyperopia and myopia, achieving phenomenal good vision with no contrast loss. And I had Presbyopia 8 years ago, and I was operating 2 days later. And I'm sure that Sri Ganesh, when he had his Presbyopia in the morning on Saturday, he was doing a live phaco the next morning in front of 500 surgeons in his hospital. So in summary, we are entering into a new era. This is new. This is really new. We have the opportunity now to treat presbyopia with LASIK, which is a 10-minute procedure that heals in 3 hours. It is incredibly safe. There have been 60 million LASIK procedures performed around the world. There is no experiment on the LASIK. We can correct pure presbyopia. We can correct refractive error from +5 to -9. We can correct cylinder very accurately. We are using spherical aberration, which is a natural aberration which the brain filters, and we do not lose contrast. We have centration with an eye tracker on the visual axis. Not like a lens inside a bag that's off-axis with an angle alpha. It's on the visual axis. So there's no change in night vision. It's tolerated by more than 95% of patients because it's binocular. It's not monocular, it's binocular. And we maintain stereo acuity binocularly. So we're entering into an era where perhaps refractive surgery for the younger patients is starting to get depressed around the world, economic problems, etc. But the growing aging population of presbyopic patients, they actually still have income. And they have already bought the house and bought the car and they have a computer. So this is a sector of the population that has never been treated with a mass production possibility. Clear lens exchange is a good procedure for presbyopia, but it's very much more invasive and it's very hard to mass produce it, especially if we have patients who need cataract surgery first. So when we're talking about the ability to use laser eye surgery to correct presbyopia without side effects, with the ability to adjust it over time if the eye changes, with the ability to reverse it easily, and if we get a cataract in the future, we can use a monofocal intraocular lens with low PCO rate, and we still have the depth of field on the cornea, on the visual axis. So you can have your monofocal, low PCO intraocular lens and restore blended vision with pseudophakia. So I am, well, you can tell I'm very excited about coming here and speaking at this conference. I want to invite you to London, where we teach a 4-day course in May. And I also want to point out that we have recorded the course from last year, and we have made subtitles, accurate subtitles, scientifically verified subtitles for the whole course. It's about 24 hours of teaching. LASIK, expert technique, complications of LASIK, Presbyopia, multifocality, all of the subjects, and of course SMILE. You don't have to watch the SMILE part because you taught us about SMILE. Thank you very much for your attention.